Ole Ljungqvist, and on behalf of CME Outfitters, I would like to welcome you to developing an enhanced recovery after surgery ERAS protocol, best practices to reduce complications in surgical patients. This activity is supported by an educational grant from Merck. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Today's activity is also eligible for ABIM MOC credit and as a CME for MIPS improvement activity. You can see instructions on your screen for details on receiving these types of credit. You can also follow at CME Outfitters on Twitter to be part of today's live Twitter conversation and to learn more about upcoming CME CE opportunities and healthcare news. As mentioned, I'm Dr. Ole Ljungqvist. I'm a professor of surgery at Örebro University in Örebro, Sweden. I'm also affiliated professor of surgery, nutrition, and metabolism at the Karolinska Institute in Stockholm. On top of that, I was one of the founders and the current chairman of the ERAS Society, which you will hear more about during this event. And now I'd like my colleagues to introduce themselves, starting with Allison.
Hi, I'm Allison Cochran. I am the Senior Clinical Data Manager at the Carolina Center for Surgical Outcome Science. We are housed within the Department of Surgery at Atrium Health, located in beautiful Charlotte, North Carolina. I also serve as the chair for the Quality Measurement and Improvement Committee for the USA chapter of the ERAS Society.
Hello, I'm Ryan Craner. I'm a consultant and an assistant professor of the Department of Anesthesiology in Mayo Clinic College of Medicine and Science in Phoenix, Arizona. I am the quality and compliance officer for that department, as well as the medical director for our post-anesthesia care unit.
I'm Dr. Richard Parrish, a professor of pharmacology at the Mercer University School of Medicine. And I'm also a board certified clinical pharmacist and fellow of the American College of Clinical Pharmacy.
Well, it's a delight to have you all on board today for this important program. To begin with, let's review our 3 learning objectives. After participating in this activity, you should be able to first describe the evidence that supports integration of ERAS protocols with the interdisciplinary team. Secondly, to employ ERAS protocols across interdisciplinary teams for the optimal management of surgical patients. And finally, to collaborate with the interdisciplinary team to routinely document outcomes and evaluate ERAS protocols. Now, I would like to start with a question for our viewers. Here's a question that you can vote on now. Are you aware of ERAS, Enhanced Recovery After Surgery Protocols? You can pick either the answer yes, and we currently have an ERAS protocol in place, yes, but we currently do not have an ERAS protocol in place, and the third option is no. Please go ahead and vote now. Here we are. The result really showed that most of our listeners do not have an ERAS protocol in place. Well, you're in for a lot of learning today. That's good. Great to have you with us. Okay, now let's start off by hearing from Dr. Ryan Craner, who will introduce today's clinical case study.
Thank you, Dr. Lundquist. So we'll get started with a case that hopefully may sound familiar to many of you. Our first patient, his name is Raj. He's a 68-year-old South Asian male. He presented for a left hemicolectomy due to localized sigmoid cancer. As you look through, his medical history is not too unremarkable for a gentleman his age, consisting of hypertension, type 2 diabetes, mild anemia, and a little osteoarthritis in bilateral knees. On physical examination, his height is 5'6" with a BMI of 26, afebrile, normal blood pressure, and clear to auscultation of his pulmonary exam. Surgical history is unremarkable for the case we're going to talk about today. As you move through to his labs, etc., his perioperative laboratory studies are significant for a mild anemia that was mentioned before. Chemistry panel is also unremarkable with a blood glucose of 136. His blood pressure is well controlled when he takes his blood pressures at home and is able to exert 4 metabolic equivalents, however, is limited by his knee pain due to his osteoarthritis. For his surgical planning, the plan was a standard laparoscopic procedure. The surgeon has requested for him to be relaxed during the operation. He completed his bowel prep at 2 a.m. and after that would continue to remain NPO until his arrival in the pre-op area. He arrived at 6:15 for a 7:30 OR start. While in the pre-op area, he received acetaminophen and pregabalin as multimodal pain management. And a APFL risk score was calculated, which put him at risk a number of 2, where you would consider some antiemetics. This patient underwent a general endotracheal anesthetic. He was induced with lidocaine, propofol, and a 100 milligram dose of rocuronium, as well as a little bit of fentanyl prior to laryngoscopy. Even a few minutes after induction, hypotension was a problem, which was thought to be secondary to his volume status after his bowel prep. He received boluses of normal saline with a grand total between 2.5 to 3 liters of saline over the case, with intermittent doses of phenylephrine as needed. Also, while the operation was ongoing, he received a total of 1 milligram of hydromorphone, 15 milligrams of ketorolac, and then bupivacaine was infiltrated at the port sites by the surgeon. At the end of the operation, of around 2.5 hours of total surgical time, he was given a dose of Sugamidex, 2 milligrams per kilogram, based on time since induction and dose of rocuronium, 4 milligrams of ondansetron, and then extubated without issue and taken to the recovery area. While in the PACU, he continued to have abdominal pain. He received an additional total of 100 micrograms of fentanyl and intermittent doses of up to a total of 1 milligram Dilaudid. After his second dose of Dilaudid, he became nauseated, and promethazine was given, 12.5 milligrams. This improved his nausea, but now he continued to be very somnolent. He stabilized, was then transferred to the hospital floor. Due to his somnolence, he was difficult to get up and no ambulation upon arrival on the floor. His mild nausea still made him hesitant to take anything by mouth and continued to have ongoing abdominal pain and the beginning of abdominal distension. At this point, he was managed even more towards the hospital usual routines, including increasing IV fluids, more opioids for his abdominal pain. The next day, he had continued to have minimal oral intake, tried a snack with a cookie, but still continued to feel nauseated, and further distension of his abdomen. And unfortunately, that evening, he began retching, and at that point, glucose was added to his IV fluids. The next day, post-operative day 2, Raj had a terrible night. Ongoing pain and distension, additional IV fluids, additional opioids administered, and finally that evening, he did get a couple hours of sleep. The next morning, Raj vomited. At that point, a nasogastric tube was placed with some return. An abdominal x-ray was performed, which was unremarkable, but continued to have nausea and vomiting. And finally, this started to resolve that evening for he continued to have some relief of his distension. The next day, he was able to sleep better through the night, able to start taking PO fluids, and as well as some small soup and crackers, and a gradual recovery and improvement from this point forward for a total of 5 days in the hospital. And as you can see, there's a few things to talk about and discuss about this case. And we will do that together after Dr. Lundquist tells us a little bit more about enhanced recovery. Dr. Lundquist.
Well, thanks, Ryan. Okay, let's learn a little bit more about enhanced recovery after surgery protocols. This was really just an idea back in 2001, but now widely accepted in many countries around the world. And this will address our first learning objective, to describe the evidence that supports integration of ERAS protocols with the interdisciplinary surgical team. Now, the case study just presented is all too common. Several problems and pitfalls were encountered all the way through. This team actually thought they were implementing and using an ERAS protocol, but let's explore a little bit more. What is ERAS? Where did the team fall short in the case of Raj? How to develop, implement, and audit an ERAS protocol, and then we'll run questions and answers towards the end of this session. Now, the ERAS Society was initiated in 2010, and we had actually done some research for almost 10 years before initiating the society. The mission of the society was to develop perioperative care and to improve recovery through research and education, which is what everybody else is doing. But we also realized that we wanted to help people implement evidence-based perioperative practice. And one of the keys to actually get this done properly is to audit what is going on, not just the outcomes, but also the processes. Now, this is shown to be in multiple papers around the world in different situations for different surgeries to result in shorter stay, reduction in complications varying between 30 to 50%. And of course, this is saving a lot of cost for care, no matter which system you're using for financing. And in fact, there's been now several studies to associate better ERAS with improved survival. The nice thing about it is that it works everywhere. So today, we have now more than 250 units in 25 plus countries where there's a full activity or activities ongoing for ERAS with the society. What makes it very special? Well, let me just take you back to the very first publication that we did as far as the guideline. And you can see a number of issues or treatments that were shown we should be doing to optimize recovery after surgery. Now, looking at this list, we realized that anesthesia will take care of a series of these elements, and other elements would be decided by the surgeon. And so far, when looking at just these two, it doesn't look too complicated. But once you realize where these things are supposed to take place, then you can see that the complexity is actually really quite substantial. A lot of people involved, a lot of decisions, a lot of care elements being managed in a very specific way by a lot of people. So it is complex, and no wonder people don't have full control. So we've been moving on from our first guideline, which was in colonic resections, to a number of guidelines. And there's been a whole range of them. You can find them all for free available on our website, theerassociety.org. But let's go to some data. We showed very early on from my own unit with about 1,000 consecutive colorectal cancer patients undergoing open surgery at that time, that with better adherence with the care elements of the ERAS Society guidelines, you actually had a number of improvements. Fewer symptoms keeping the patient in the hospital, fewer complications, and fewer readmissions. And all in all, shorter length of stay. Now, we followed up on these patients 5 years later to see how they were doing. And you can see here that, in fact, with the higher rate of compliance, above 70%, there was a 42% risk reduction in actually dying 5 years down the line. So how did we actually achieve that? Well, we kept the patient's journey in full control. We have an integrated ERAS protocol from pre-admission through clinic, pre-op, anesthesia, operating rooms, post-operative, and the ward, and all the way home, and then a follow-up 30 days after the operation. And there's a team that audit the outcomes and the compliance with the elements to make sure that we're actually doing it the right way. Now, that we know a little bit about ERAS, I'd like to invite the entire faculty to take a closer look at Raj's journey and see where things could have been improved. Now, specifically, we look at factors that contributed to his extended hospital stay and consider how ERAS could have improved things for Raj. Now, which factors contributed to an extended hospital stay? And how could a current fully implemented ERAS protocol have helped? Now, before we move on, I'd like to ask another audience response question. So please go ahead and look at these questions and vote for one of them. Because Raj has a type 2 diabetes mellitus, would carb loading have been appropriate in the preoperative phase? You can answer yes, a carbohydrate drink containing mainly maltodextrins is preferred, or yes, Gatorade would be the preferred carbohydrate drink. Third option, no, a little glucose and more saline would have been indicated. And fourth, no, the patient was instructed not to eat or drink after midnight. And the fifth option, I'm not sure. Let's see. So I'm going to turn now to Richard. What do you think of these results, and what do the guidelines actually tell us?
Well, Dr. Lundquist, that's not surprising. Many people would probably shy away from giving glucose or anything of that sort to a diabetic patient prior to surgery. But in fact, what multidextrins actually do is to reduce the hyperglycemic variability in both diabetic and non-diabetic patients, even if they get dexamethasone. So while the results are not surprising, the guidelines say that yes, you should give adequate carb loading with a multidextrin.
And that goes along with their medication, right? The morning medication.
Absolutely.
Yeah, because then
Absolutely.
actually get the benefit of changing metabolism before surgery. So very appropriate. It's interesting also to see that a lot of people like to give saline. We'll come back to that, I think, a little bit later. Now, is there anything else here that we might want to discuss? Well, actually, I'd like to ask Ryan. There's the NPO, and also, let's see, he was also given a bowel prep. How does he present to you when you're trying to put him to sleep?
Yeah, this is an interesting one. I'm not one to delve into the land of bowel prep pros or cons in terms of, we know there's ongoing debate, but whenever
we just know that it's done. So
yeah, there it is. So especially in this patient's, right, the guy unfortunately was probably relatively hypovolemic, and then on top of that, he did the traditional NPO after midnight, or nothing by mouth after midnight. Now the idea is too, with even the ASA guidelines within the United States that allow patients to have clear liquids up to 2 hours prior to undergoing surgery. So this would be a good case too. And again, this is part of the robustness that needs to happen in terms of a good pre-op discussion and planning, is that even if he does take a bowel prep, to allow him to take clear liquids, including this complex carbohydrate drink, to maintain close to euvolemia as possible prior to induction of anesthesia. Because unfortunately, I believe in Raj's case, when he starts out the case relatively volume depleted, it leads to a lot of problems further down the road, which we'll talk about even more.
Yeah, we can move to the next one, the intraoperative phase. So maybe you could just continue, because something happened right off the bat.
And I'm sure this has happened to almost everybody that's been on this call or on this meeting that we've seen before, where they, even after induction, after the induction agent is worn off, where you're continuing to chase the hypotension, likely due to hypervolemia. And we continue to administer more and more crystalloid in this case, or some normal saline in this case, to try to improve and find out where we are and improve his volume status overall. And that's a big part too. And we talked a little bit about normal saline in this case as well. There seems to be even more and more literature regarding the importance of using a balanced salt solution, such as lactated ringers versus plasma-like, even though they are incrementally slightly a little bit more expensive, but probably better off for this patient, especially to avoid the hyperchloremic acidosis associated with normal saline resuscitation.
Yeah.
But that's it. You start out behind, and then it's really hard to find your place and figure out where you are during the case until you just keep kind of pouring the volume in over and over. And then the other big step, and which unfortunately probably did not help this patient too, is the long-acting local anesthetic, or excuse me, the long-acting narcotic and
Yeah.
very, very reduced pain management regarding just local infiltration of the site.
Let's come back to that a little bit later. I wanted to ask you, because I'm the surgeon here and I'd like to have my patient relax. Can you comment on that a little bit, and especially with respect to COVID and everything going on?
Absolutely. Yeah. So as many as you know, especially with the ASA guidelines initially, when COVID, I would like to say COVID's abating, but that doesn't seem to be the case. But when it was first peaking, the importance of using techniques to avoid coughing or aerosolizing, airway secretions as best as possible. So we, at our institution, I think at others too, we're using larger and larger doses of rocuronium to get rapid relaxation without needing to, bag mask the patient or anything. So they were ready for essentially a rapid sequence induction. This was associated with, and I think it has been across the board, with higher doses of rocuronium, which do optimize in terms of conditions for insufflation and laparoscopic procedures, but it still matters too when it comes time to reversal, which is a very thing we're going to talk about here at the end.
Yeah, we'll come back to that right away. In fact, I got a question here for the audience again, an audience response question. So which of the following is true? Let's see if we can, which of the following is true about the dosing administration of sugammadex, an agent used for the reversal of neuromuscular blockade induced by rocuronium bromide or vacuronium bromide in adults undergoing surgery? Choices are: it is based on depth of block regardless of actual body weights. Second, it's based on monitoring recovery of train of 4 TOF ratios, or it's based on time since induction, or it must include co-administration with an anticholinergic agent. And the fifth choice, I'm not sure. Let's see what.
See how it comes out.
Okay, Ryan, a quick comment.
Yeah, again, I think the anesthesia folks have made themselves present there versus the ones that are not.
Yeah.
It is, and this is an important part. It's hard. We can talk about hours regarding monitoring, but it is based on recovery of the train of 4, depending on the number of twitches the patient has. And it's important to base your reversal dose on at least some sort of objective findings. And again, we could go on and on regarding EMG versus train of 4 versus positioning versus accelerometry, which we can talk about later. But it's important to have at least some form of monitoring to base your reversal dose.
Yeah. Well, thank you, Ryan. Let's move to the immediate postoperative phase. Now, here we have a lot of things actually going on. And in my experience, when we've been training hospitals and seeing what's going on, this is a place where a lot of things can happen. And actually, it's a place that needs to be very much involved as a team, as part of the team, because this is really a crucial part of the, something's going on. Anyway, a very important part of the journey. So in particular here, this guy is actually, he has a bit of pain and he's nauseous. And what do we do about that? Maybe Richard, you want to comment a little bit about pain management? And he's been given quite a bit of also opioids, and he's given more here.
Yes, that's for sure. And one of the things that's striking about it is really that he wasn't given any NSAIDs or just one dose of an NSAID, and probably not routinely and in the follow-up. So naturally, more opioid is often given. And then the vicious cycle starts about pain control, then nausea, vomiting, and the like. Multimodal pain management and multimodal nausea and vomiting prevention are key in this instance.
Yeah. Could you just briefly give us the basic idea between that multimodal approach?
Yeah, with the basic concept is that you use agents that have different mechanisms of action that are trying to exert the same effect, and also to reduce the opioid exposure that patients have by using other agents and agents that actually don't cause nausea and vomiting for pain management. So you in effect get different mechanisms working on the same kind of outcome.
Yeah, perfect. I think that that's something that we use a lot actually within ERAS in multiple ways to achieve certain functions and returns of functions as well. Okay,
Absolutely.
let's move to the postoperative phase on the ward. Let's see if we can. Yeah, here we are. So, well, this guy had a bit of a ride, actually. Unfortunately, he wasn't feeling too well. He couldn't eat. He was nauseous, distended. I don't know if anybody has recognized this kind of patient. I certainly saw them a lot before we started with ERAS. Maybe just a comment on this gut standing still, because that's really what's going on. Do you want to start, Ryan?
Sure. So it's interesting, the number of things that have been associated with assumingly a postoperative ileus. You know, we talked a lot about fluid management initially, and we can discuss that more, but that probably plays a large role. Opioids, peri and postoperatively, also don't aid with that.
Yeah.
And one way to avoid and to try to avoid the opioids is to try to use some sort of regional anesthesia. And you mentioned in your guidelines, especially when you did a lot of open cases, an epidural anesthetic was likely is the gold standard. But for laparoscopic, there's other regional techniques that can be used, including tap blocks, rectus sheath blocks, all of those things to try to help reduce the pain and then also reduce the opioid consumption, which hopefully will reduce the likelihood of an ileus postoperatively.
Yeah. Well, in the US, you have alvimopan that can be used as well. So that could be a choice. Unfortunately, we don't have it over in Europe, but that could certainly be a choice. And there's also the option of, well, if the patient actually can take anything by mouth, you could serve some coffee, and actually just eating helps move the bowels as well. But of course, this guy never really made it that far. It took him a few days.
Indeed.
And by way of introduction on how to set up your own ERAS program, I'd like to show you this simple slide that shows that an ERAS protocol highlights a number of different things that happen over time, and many of them should happen in parallel with the involvement of people working with the surgical department, anesthesia, and nursing. And it really starts before admission and then runs in the preoperative phase, intraoperatively, and postoperatively. And it's about getting things right from the beginning, because if you don't do things right, like unfortunately in this case, there's no way you're going to be able to have the patient eating and drinking and getting out of bed in the postoperative phase. So it's about handing over the best possible treatment in the patient when you hand over to your next in line, so to speak. So let's move on to some best practices. We'll just address our second learning objective, and that's to employ ERAS protocols across interdisciplinary teams for the optimal management of surgical patients. And before we discuss best practices, let me ask our last audience response question. If you're using ERAS, would you be able to provide data on compliance with ERAS protocols and subsequent outcomes? Answers are yes, no, not sure. I would need to inquire with administration. Yeah, so a comment to this, it's really good to see that 23% of our audience actually do monitor compliance. That's very, very impressive. Usually when we have these kind of sessions, it would be below 10%. So certainly it's picking up. That's very good to hear. What we're seeing with no data available or not knowing, that's probably pretty much the same answer, I would guess. But that's more common. And in fact, this is really a very, very important part of this. So now I'm going to turn to Allison. How do we establish the team when setting up an ERAS program?
Yeah, thanks a lot. So really, in order to build a successful team, you first really need a motivated surgeon or anesthesiologist champion. In a similar way, you also need to find a motivated nurse or APP champion. And really, this is critical because they will be the boots on the ground, if you will, really to make sure that all the ERAS elements are taking place and that they are being adhered to. Next, and this is really important, you'll hear me talk about this a little bit throughout my entire presentation, is really an administrative champion. This is just as critical because they can provide that financial and that process support while kind of being able to speak the language of administration, which, can sometimes be a bit of a challenge, right?
Allison,
yeah.
can I just comment? Well, because this is really very, very important, because people think that it's actually expensive to run ERAS, whereas in fact, this is probably one of the best savings that any hospital can make, because the cost of complications and keeping patients in the hospital is much, much higher than any investment in a team that you can ever make. And there's been multiple data in the literature to show this from virtually every country and every economic system. So I'm glad you brought it up.
Yeah, that's right. Yeah, you're absolutely right. It's all throughout the literature in terms of ROI on an ERAS program. So that's why I really emphasize getting that administrative champion who can help you speak that language, that financial language, and that administrative language. In a similar way, kind of moving on from that is accountability, right? So frequent, recurring, and I would emphasize mandatory ERAS team meetings are really critical to building and keeping that momentum going and to provide that space for feedback and for discussion while you're building your ERAS team, and also facilitates that quick interactive and iterative change that you need to quickly change practice. And finally, don't forget that there's a lot of support available out there, and the ERAS Society also has a structured ERAS implementation program. So we've identified our team now, right? But how do we get the buy-in? When you're first starting, you really want to make sure that you hold discipline-specific meetings, and then so meetings with nurses, meeting with surgeons, meeting with support staff, etc. And really make sure that you gear your messaging towards them. And I would say do that with enthusiasm, right? So you want so you can get a lot out of people and getting a lot of people on board just by really being excited about something. I highly recommend continuing to hold these discipline-specific meetings, particularly for the first few months, because they can give you that opportunity to really tease out what challenges each particular team type is having. So if your support staff and data entry team are having challenges, you need to know about those, but you also need to know about if there's any nursing related challenges, et cetera. And finally, communicating successes to all those clinical and data team members is incredibly important. But again, don't forget to tell your administrative champion, because again, their buy-in is so important. And a lot of times it's really overlooked, particularly because they're not always necessarily up there in that clinical space.
Allison, you're touching on so many important things that is really key to what we're trying to achieve here. And one of the things is feedback that you just mentioned with the meetings with everybody involved, because that, to me, that really helps people understand what their particular role is in the bigger picture, and understand that perhaps what they thought might be happening all the time actually isn't. And it's so I think that's a very important part of getting the engagement, because everybody wants to do the right thing, but it's not so obvious that what is the right thing and that it's actually being done. And I've been finding that many times that pulls the team together and the group together. What's your experience?
Yeah, so that's exactly right. So a really critical component of those team meetings, whether they're discipline specific or overall ERAS team meetings with all the interprofessional people involved, is data. We'll be talking a little bit about that later, but it's so critical to be able to tell the members of the team, you know what, you think you're doing this, but the data say you're really doing this. What can we do, you know, to improve that compliance or to improve our practice with that? So, so these team meetings really do need to be data driven, but also need to be a collaborative space, right? So that everybody can talk about the challenges that they're facing.
Yeah.
Yeah, so so in terms of the guidelines, adapting the guidelines to your institution will really go a long way towards successful implementation. An example of this I like to give is pre-op carbohydrate loading, right? So your institution may not have the support, may not be able to support like a specialized formula, in which case something like Gatorade to begin with may be a suitable alternative that helps you to adapt both to the patients and to your hospital resources. So it's important just to get started, and adaptation allows you to do it, but it's also important to remember that that's a balance that you have to maintain. So you want to be able to adjust practice to what your local resources are, but you don't want to stray too far from this concept of eliminating variation in care. So something to keep in mind on that front. And finally, here's a brief schematic of the ERAS implementation program that I had mentioned earlier. It's a very structured program provided by the ERAS Society. It's comprised of 4 seminars that are held with your assigned EIP coordinator. So you're given a coordinator when you sign up for the program who really guides you through all of these stages. Between each seminar, there are these homework periods that I think are really important because they give you the time to work on practically implementing some of the strategies that we kind of talk about in theory, right? So we talk about how data entry and data collection is important, but how do we actually do that given what my hospital or my institution looks like and what my resources are? We talk about getting buy-in, but what does that practically mean? How do I practically get buy-in, again, given my institutional resources? And then at the end, we have seminar 4, which I always like because it really helps your team. Your team gets to celebrate all the hard work they've been doing over the implementation. So thank you.
Well, thank you, Allison. I think we should also mention that the ERAS USA is running these implementation programs. And now with the COVID around, we're doing a lot of these things online, obviously, but it's worked out actually very well. So you can check out those websites if you want. I'd like now to turn to Dr. Parrish for a discussion about pharmacotherapy perspectives, because there's a lot of pharmacology that could go wrong and certain things that you can do to actually make sure that they go right. So I'll hand over to you. Sorry, I think you're mute. Yeah, here we go. I think we can hear you now.
Great.
No.
Thank you.
Yeah,
Dr.
here we go.
Very good. There are many ways for pharmacotherapy and clinical pharmacists to aid ERAS development and implementation. Most hospitals have computerized provider order entry and electronic health record systems that have replaced manual order entry and paper-based patient charts. In addition, those that have implemented ERAS protocols do one surgical specialty at a time, typically. And research shows that ERAS patients need to be clearly identified in these systems throughout their stay for program compliance. Further, pre-formatted order sets and care pathways that subdivide the patient's surgical journey into pre-admission, pre-op, inter-op, and post-op phases are most effective for assuring ERAS elements. Finally, many of these systems incorporate clinical decision support for assessing the risk of common postoperative complications. In this way, the use of ERAS protocols with audit and feedback will also help the organization to meet various healthcare quality measures. Organizations have placed clinical pharmacists in pre-admission clinics working under collaborative practice protocols to assess and prevent drug therapy problems by a thorough review of the patient's current pharmacotherapy. This review identifies high-risk medications such as chronic steroids, immunosuppressants, and anticoagulants, as well as high-risk conditions such as smoking and anemia, which, if left alone, might interfere with the patient's recovery. Other areas where collaborating clinical pharmacists have been deployed include the surgical suite and patient wards, where improvements have been documented in prophylactic antibiotic administration and multimodal pain management through opioid stewardship programs, as well as protocolized care planning for prevention of common complications, such as acute kidney injury, postoperative nausea and vomiting, and hyperglycemia. In summary, pharmacotherapy pearls in this case include applying ERAS and collaborative approaches to reduce treatment variation through protocol standardization and risk assessments embedded in the CPOE and the electronic health record, using COX-1 NSAIDs like ibuprofen or ketorolac to reduce opioid exposure, even in patients with diminished renal function. Carb loading with multidextran that provides high energy content and low fluid volume, even in patients with diabetes. And active involvement in with clinical pharmacists in creating and implementing ERAS protocols to optimize pharmacotherapy in all phases of the operative journey.
Perfect. Thank you. Thank you very much. I think I'm going to now just turn over to Ryan, because I know you have a simple approach to get team members involved. Could you just explain a little bit about this, the crayons we see here?
Yeah, I don't know. Maybe it's an attempt to be frugal. No, this goes back to Allison in terms of team building. So a colleague of mine in the ENT department, she was trying to implement specific enhanced recovery protocols within her division. So she brought she got the guideline document out, looked at the certain points with their evidence, and presented this document to all of the members within her group. And with crayons, again, cost effective, red, yellow, and green, she asked them to mark the things that they thought they were doing, the things that they wanted to do, and the things that they were hesitant in doing. And with that, and then with comments, and then with that, she was able to merge the whole department together to say, all right, well, these are the things that we think that we're doing. We need to make sure that we are doing those things, like we said, which is part of the audit process. And then a lot of times the things that they weren't sure about or didn't want to do were actually just in a question of what their practice was. So for example, you see some red ones over there on the thing, which was essentially DVT prophylaxis for tonsillectomies. That was his concern. Right, so there's things like that that are readily and easily reconcilable, but you got to get it. This was a chance to get everybody on the same page about the things that they thought were important, and then how to make sure that we were doing those things and doing them well.
Yeah, I think that is really the key. It's very, very important. And in fact, when we started all of this many years ago, it was our own experience that we thought we knew what was going on, and when we started to measure, we realized we were all wrong. So it's about measuring, and that brings us actually into evaluation of any pathway and protocol, because that is really the key. So in just a moment, I'm gonna ask Allison to tell us a little bit more about this, but because this is really addressing our third learning objective, which is collaborate with the interdisciplinary team to routinely document outcomes and evaluate ERAS protocols. Because in my view, this is the future of care. We're not going to deliver care without knowing what's going on in the future. We've done it forever in the past, but it's amazing that we've been getting by with it, I think, in a way. But Allison, tell us, what about auditing an ERAS program?
Yeah, thanks a lot. So this is my favorite subject, which is data. I could probably talk about this for another 3 hours, but I won't. So we know that ERAS is really only successful as an equal part of that evidence-based protocol, but also the data audit component, that audit of compliance to that protocol, as well as your outcomes. So, as they say, you don't know what you don't know, but the data tracking, provides you with that knowledge. So you do know what you didn't know before. We also know that empirically that the higher the compliance, the better the clinical outcomes. There's a large body of literature showing this, and I think Dr. Lundquist showed it a little bit earlier in the presentation. But finally, and particularly in this data-driven world, data facilitates that necessary feedback loop to continue to refine practice. And as previously discussed, having those recurring ERAS meetings is a great place to present the data on a regular basis. But it also provides data to support messaging to stakeholders, to your administrative stakeholders, to your clinical colleagues, for example, as well. And research always, data always provides good backing for research if that's something that you're into, or quality improvement projects. So the best choice when you're trying to decide who will actually be doing the data collection, and that's probably what you're thinking about right now, it's going to have to be somebody with a clinical background. A lot of times this looks like a dedicated ERAS nurse or an APP. But again, the data are very complex, or very clinically complex. And so it is important to have somebody with a bit of a clinical background. In terms of collecting the data, the EIS, which I'll be talking about here in a second, it is a great database to use for ERAS data tracking, but really it's important just to get started in terms of data collection. So if you have a homegrown database or in a local internal database, that may be necessary just to help you get started, just to help you get going. And in terms of what data to collect, I will refer you to the Recover checklist, which is shown here, which really describes all those data points in detail. So what you see on the screen here is a snapshot of the ERAS Interactive Audit System, which is the official ERAS data registry, which mirrors the ERAS guidelines, and it's used all around the world. So not only do you put the data in to the EIS, which of course is important, that's data collection, but you also get very robust and meaningful analysis out of it. So the data don't just sit in there and do nothing. They can be actively used to drive compliance changes, to drive outcomes changes in real time. And here's just a look at the data entry user interface. Again, it's all designed to be user-friendly from a data entry perspective. And here's just a small example of the analyses that you can get back from the EIS. So very meaningful graphs. They have trend and data analyses that it does for you. So, you don't have to hire a statistician like me to do all of your monthly ERAS reports. The database does it for you, as well as having the ability to create these custom groupings if you want to dive deeper into your patient population. So maybe you want to compare smokers or non-smokers, or people who got a particular, oral carbohydrate loading, or those that didn't. It allows you to create those custom groupings, and it gives you the analysis back to you. Thank you.
Well, thank you very much. I'd like to thank the entire panel for excellent presentations and insightful discussions so far. Now, before we start the audience Q&A, by way of summary, let's take a look at our SMART goals and then revisit a few of the earlier ERAS questions and see how we do. Now, SMART goals: specific, measurable, attainable, relevant, and timely. If you're currently affiliated with an ERAS institution, how about considering sharing your data on improved care and outcomes? Audit your ERAS program to ensure you're achieving ideal results. Or visit our website. That's one for you to remember. For current ERAS Society guidelines, like I said, all the guidelines are available for free download. We also have implementation programs that we've been mentioning to you today, and a lot of other resources. If there's also our US group, the erasusa.org is another one that will get you to the same kind of information. But if you're not currently affiliated with an ERAS institution, identify potential champions for your own ERAS program. Set up a meeting with key stakeholders to explore benefits of ERAS, and read some of the literature. There are some reviews around that would give you the sort of the overall view, both from a financial view, but also from a clinical point of view. And they also, many of them explain why this is working, which we really didn't have time to talk about, the pathophysiology and what we're doing to the patient's bodies actually by reducing the stress of surgery. And thirdly, apply ERAS guidelines and protocols for optimizing management along the surgery continuum of care: pre-admission, pre-op, intra-op, and immediate post-op, and the post-op phase. So for now, for those of you who do not currently have an ERAS protocol, now that you've learned a little bit about ERAS, would you consider one? Please go ahead and vote either yes or no now. Great news. We will do whatever we can to support you. Just go to our websites and we can help you, definitely. Or you can go with other people as well that do these things. But we're very happy to help you. But let's go back to Raj's case again. He had diabetes, you may recall, and we asked, would carb loading have been appropriate for the case? Why don't we answer the same question again? I think, well, you can answer yes, a carb drink containing maltodextrins or Gatorade would be preferred. No, a little glucose and more saline would be indicated was another answer. And no, the patient was instructed not to eat and drink after midnight. Or the last one, I'm not sure. Please vote again. Yeah. So, Richard, do you want to comment?
Well, the best answer for this is a drink that contains complex carbohydrates such as maltodextrin. Gatorade is a possible option, as Allison mentioned, for those that are concerned about the financial impact, but certainly a little glucose and a little more saline are certainly not indicated. And the patient really, as in the past, we've told the patient to not eat or drink after midnight. And so that's not an appropriate answer for today's treatment. And even in a diabetic patient, they should get carbohydrate before their surgery.
Yeah. Well, the whole idea, actually, I invented this idea many years ago, actually, and this is how I got into ERAS. And the whole idea was to get the body set in a fed state as opposed to a fasted state. And to achieve that, you actually need to give a pretty decent bolus of carbohydrates, and it needs to be highly concentrated. That's the trick, because then you trigger the insulin release. And so Gatorade is a sports drink. is made not to give an insulin response, but like Allison said, it could be a substitute just to get people used to giving some sort of drink. But in fact, to get the maximum effect, it's a maltodextrin, like Richard was saying.
And then,
okay,
if I may, so this is
please.
Some people that may be hesitant as well from a preoperative standpoint. I mean, the ideal is to have the patient take this drink prior to even arrival in the hospital, right? So they drink it, it's 2 hours before anesthesia. It's something it's a little tricky to do in the hospital itself, right? But if they're instructed to take it, depending on the timing and how your institution works, 2 hours, 3 hours before their planned surgery time. That helps make sure all the guidelines are all filled and everybody's happy from every aspect of it.
Yeah. Well, just a quick other one I can't resist just to mention, because people say, well, can't you take any drink? Why don't we give Coca-Cola or anything? And in fact, there will be other drinks that might work and have the same effect, but they haven't been medically tested. So the ones that you should be using, you should ask the manufacturer for their documentation that it actually works and that it's safe, not least. Okay, let's move to the other one. Here's our last recap question. Which of the following is true about the dosing and administration of Sugamadex? You remember, is based on depth of block regardless of actual body weight. It's based on monitoring with the TOFs. It's based on time, or include co-administration with anticholinergic agents, or I'm not sure. So let's do that one over again, please. Right. Quick introduction to a part of anesthesia, I guess we've had today, right?
That was, we immersed them into the world of rocuronium and Sugamadex.
Yeah. Well, cool. Okay, that's great. It just shows us that people have been listening well. That's great. So let's get started with our Q&A. To ask a question, just click on the Ask Question tab and type your question. And please include the faculty member's name if the question is for a specific person. And there's been a number of questions already that came in. And I'll just, okay, from a conception to implementation in an average size hospital, how long is reasonable to expect that the ERAS protocol will be implemented? How long does it take? Well, I could start off and I'll have you guys fill in. Actually, with the protocol that we're running with the ERAS Society, you start employing ERAS protocols after the second seminar that Allison showed you. So that means that you actually start treating patients with full ERAS about 3 months after you've started. So, and then you gradually bring it into every patient. We ask you, the teams usually, to select a little bit for the first 2 or 3 cases, and then move into all of them. And then basically the rest of the training is fine tuning and managing issues. Ryan, you want to comment on that?
Absolutely. So I agree that, especially when we've done these implementation, there's so many cases. For example, if we're using the product we talked about, you have to get a baseline. So you look at the data from your previous cases before you implement the guidelines. And then, yes, you can get going about 3 months, but it is an ongoing process. And Allison mentioned about this too, and I'll turn it back to her in a few minutes. But the ongoing looking and reminding and work to keep everybody on task and involved and bought into the process, I think that will also affect how quickly it fully comes to fruition, because you got to stay on task instead of kind of lapsing back into maybe not great habits, which is real, especially depending on the size of your group or the program that you're instituting. But again, I would say it probably took us 6 months to really get to the point where we were doing things pretty reliably, but then there's always a little bit of backslide that we still have to stay up on. Mm-hmm. Allison, what do you think?
Yeah, I mean, I think like overall, you could, if you had to put a number on it, 8 to 10 months or so, but it's definitely an iterative process. And so like while you're undergoing ERAS implementation, you're absolutely right. There's 2 steps forward, 1 step back, that sort of thing. But the way you know that you're doing that is through constant reporting of what's going on at those recurring, and I would say mandatory, ERAS meetings. I think too, there's something to be said for talking about a mature ERAS program program as well. So we're talking about a very early ERAS program, right? The first 8 to 10 months or so. But once an ERAS program becomes mature, there is a tendency to kind of just go, well, it's on autopilot, everything. I'm sure we're still doing everything fine, but that's where you get into trouble. And that's why tracking that data, those compliance data is so important.
Yeah, I think you're absolutely right. We had another question. How long does it take an implementation program? Well, like we said, we run the programs over about 8 to 10 months usually, but in fact, you get going with it much earlier. So I think that answered the question as well. While we're on it, there's another question. Aren't ERAS much more difficult to implement in elderly patients? Who wants to take that one?
Oh, that's a great question. I think what a lot of people would probably have that question as well. The research that people have been contributing to the literature shows that ERAS can be implemented in elderly patients or any patient really, regardless of their age, as long as the protocol is followed. So not a problem with elderly.
We found that because we had that question a lot. ERAS is fine for all the healthy ones, but you can't do it on this patient because he's too sick. But in fact, it's the ones that have the comorbidities that are going to gain the most because they have organs that are vulnerable to stress. And that here's another question actually about the pathophysiology of what are we actually doing? Well, we're reducing a lot of the stress to the patient with all these different elements. They do what we talked about before. It's a multimodal approach to reduce the stress, to get normal function in the organs that we want back in shape, such as being able to move around, being able to get the gut move, and then to avoid pain so that you can move around. And that's been explored a lot. It reduces insulin resistance, which is one of the key aspects of all of the response to surgery, but it also reduces the inflammatory responses that may play a part in all of this. So I think it all comes together very nicely. And in fact, the vulnerable patients are the ones that are gaining the most from it, I would say. Maybe Ryan, you've seen them shorthanded in the ICU, et cetera. Maybe you want to comment as well.
No, I think you're right. I mean, that's the goal is, like you said, the ASA for speaking anesthesia, the ASA or the class 1s and 2s, they can tolerate a hit pretty well either way, but it's the ones that are ASA 3s or 4s or the emergency cases, which are the ones that you need to do. I think we have to do a better job in terms of targeting them and keeping their physiology as close to normal as we can. And I think they are the ones that benefit the most.
Yeah. And just a quick answer, the ERAS protocols are fairly similar across different surgical procedures. And that actually is, so you start with one and then you can fairly easily spread it to others, actually. Okay, we've had a couple of questions here about low-income countries and what can be done for them price-wise. Is it more or less expensive? Is it less expensive to get training in these countries? And I would say in general, yes, it is. Because the cost for the training is related to IT systems, but it's also related to the cost for the teachers. So that is certainly something which is balanced just like everything else, I would say. Okay. Another quick one. Did you get a lot of pushback when you began the ERAS protocol processes? Ryan, you want to start off?
Yeah, I do. So it depends. It's interesting because it kind of did depend a little bit on the surgical specialty, and we're still rolling them out. So for like Dr. Lundquist mentioned, some of them are very similar, so it's easier to do. So colorectal to, for example, GYN surgery, some similarities. And so it was pretty easy. And once the colorectal surgeons started having more success and they shared that with the GYN surgeons, those things began to be, it was easier, the fire kind of spread. But that was the important part about having that document. Again, that little silly crayon thing that I mentioned was that you can see where people's concerns lie, and then you can address them in real time. And it's hard too, because sometimes, like, for example, if it's a checkbox for anesthesia, for example, it's like the checkbox to this point has been, did you actively warm the patient? It's like, well, yes, I applied the bear hugger, I did that. But really the question should be, did they get hypothermic? Right, because that's, the body doesn't care if you apply the bear hugger if it's still cold, right? And that's a lot of the parts that I'm trying to I act with surgeons, and especially our orthopedic practices, is like, I understand that you like to be really cold and you like to see your breath in the operating room. It needs to be 1 degree above freezing, but we've got to do something better to help this patient stay warm, to just in general. So it's things like that where it's like, well, if you understand it, then it's usually easier to get people to buy in, even though we're slow creatures to change. But a lot of times if they get it from more than one source, then it's easier and they get a little more buy-in, and then they can kind of catch the momentum. Mm-hmm. So dependent on the service, some services were a little more resistant and other ones are early adopters, and it just sails through.
Yeah, I was going to mention that kind of diffusion of innovation curve that we're all maybe familiar with is that early adopter to late adopters, and I think that's where it's important to have somebody that is enthusiastic. Your surgeon or anesthesiologist champion is enthusiastic, because they're now going around talking about how great their outcomes are and everything now that they've done this ERAS thing. The other perspective from that too is that administrative champion, because they can in some ways compel some of your late adopters to do these things once they see how there's an ROI and how it helps improve patient care. So that's why it's important to have these champion types, I guess.
Absolutely. I would say in Alberta, when we implemented it in Canada, the leadership at the top, physician leadership and administrative leadership, were hand in hand. And it included also anesthesiology, included nursing, it included pharmacy, it including gastroenterology and nutrition. Gastroenterology can play a very important part in this as well, in terms of the science and also in implementation, because they're consultants and they see a number of may consult at different hospitals. So when we did it in the 6 hospitals we started with colorectal, that's the team that we had together, and then the challenge was to see how fast it could go.
We've mentioned several times that we want to get the administration involved, and we got a question here. How does your administration use the data, carrot or stick? Which is why not? It's a really good question, because you could get concerned that they would just start giving you trouble. But in fact, what I've been seeing is that ERAS delivers from the people on the floor what the administration want to achieve but can't, many times, if I put it that way. I mean, what they're seeing is that, hey, when we're handing it to the people who actually deliver the care on a daily basis and help them see what they're doing and help them manage these things on their own, they get really good results that saves a lot of cost for the administration. And what we're seeing in more and more hospitals is that we start with one typical surgery, and then the next thing you know, administration, as soon as they start seeing the data, is asking, okay, how about we do this for this and this and this?
Yeah.
So I think it actually opens up a much better communication. And I think it's been extremely helpful in actually improving healthcare in general, because we need those guys as well. They have to make ends meet. And at least I don't know how to run hospitals. So we got to do it together.
Yeah, I would add on to that too. Not only does ERAS facilitate some of these, administrative goals like reduction of length of stay and complications, and improve patient satisfaction, which is a big one, right? But also as we turn to more value and quality-based compensation models, ERAS elements can be components of that, and can drive some of those models. So that's we do a little bit of that here at Atrium too. So
okay, I'm gonna give Ryan a chance to talk about Sugamadex, because we have several questions around. First question is, why did the patient get Sugamadex? Are there any benefits versus neostigmine?
So that one, in terms of postoperative respiratory complications, that's one benefit that it seems to hold to and across the literature in terms of, in addition to the time or how long it takes to reverse, potentially the postoperative nausea vomiting with neostigmine versus Sugamadex. I don't know if that's been teased out, especially as a head-to-head comparison, but historically, right, the neostigmine dosing and question of worsening nausea vomiting. But again, we always worry about the respiratory complications, and it does seem to help in terms of reduction of those, including pneumonia, et cetera. Again, the literature hasn't teased it out all the way, but that's one of the benefits, and that's one of the reasons that we use it for. And it does seem to help people without this anticholinergic side effects as well in the post-op environment too.
Any specifics about dosing that?
So if you do look at the package insert from the manufacturer, it talks about the 2 milligrams per kilo if you have twitches that are present versus 4 milligrams per kilo if you have post-tetanic twitches that you can ascertain, versus the 16 milligrams per kilo for the immediate reversal after a high dose of rocuronium. Where I work too, we got a little bit lazy because we had Sugamadex around, and so we weren't necessarily doing great monitoring. And that did, and so people were like, well, this should be gone by now. And if you didn't monitor, then all of a sudden they were still occasionally they have people that would come through the recovery room and still complain of subjective weakness. But they would then get redosed with Sugamadex and it would get better. So I think it's the same principles of anesthesia that have been around since the use of neuromuscular blockade. Is if you're going to monitor with whatever way you're going to monitor it and get it to a goal of whatever you want, 1 to 2 twitches, something present, and then use it appropriately for that point. You just have to keep using the same solid principles that have been there forever. Don't get lazy.
No. Okay, here's one for Richard. I think we didn't comment on the fact that patient didn't get any PONV prophylaxis. I think that was purposely so. People think it's being done, and sometimes it isn't. But maybe you could comment a little bit more about that, Richard.
Sure. Well, in this case, it didn't contribute to the patient outcomes, so we didn't include it. But the patient would likely get PONV, get BT prophylaxis. Is it BT prophylaxis?
No, PONV.
PONV prophylaxis. Yeah, PONV prophylaxis. The patient probably would qualify to get PONV prophylaxis. And if you have 2 risk factors or more, you really should be using 2 agents or maybe 3 agents prior, and then considered as a scheduled med, and not just waiting for nausea and vomiting to occur. So,
yeah, I think that covers that. Okay, another specific question, I think, for you or Ryan. How long would you have continued with the ketorolac? Yeah, that's the question.
Well, for safety, the typical length of therapy is 5 days for ketorolac. Usually, people cut it off around day 3 and or switch to ibuprofen if they're going to go home. That's typically the course that most hospitals follow, and we try to get them orally before as soon as possible, so that we're avoiding IV lines and IV fluids and using the gut for oral absorption.
No, I agree.
Ryan?
Yeah, that's exactly right. We schedule the acetaminophen, right? Just try to keep that going, and then exactly right. The IV Toradol versus the ibuprofen and make that transition as soon as it's as possible. But got to keep it scheduled for at least, like you said, at least 4 or 5 days or so.
All right. Here's a question that I think is an interesting one for me from Europe, because the U.S. view on this is completely opposite to European. Because in Europe, we're not allowed to document and specifically categorize our patients by ethnicity or race. Whereas in the US, I think that's almost mandatory, isn't it? So the question here is, in your hospital, do you see any racial or ethnic disparities in how the ERAS protocol is applied? Or have you heard of any?
So I haven't seen much of this in the literature, which kind of indirectly implies that there may not be a significant disparity. But I will say that because ERAS is meant to be applied to every single patient in the same way, it should help to eliminate some of that variation in care that that may come from bias or something like that. But that's really all I can say about it, because I frankly haven't seen a lot of disparities research.
No. Anybody else? Seen? Oh, no. Okay.
Mm-hmm.
I think by protocolizing in general, it makes it very difficult to get away from giving the same care. So I think that helps. Okay, we have several questions on implementation and data management. So I thought we would focus on that for the last 10 minutes or so. One question is, so you actually did not use ERAS in your patient case? That's true. They thought they were doing it, like many do. And in fact, when people have been writing about this and asking people and checking what they're doing, compliance levels are usually between 40 and 60%, 40 to 60%. So there's a big improvement to be made for most cases, actually. So let's talk about, how do you run these team meetings? How can we get everybody brought in? So Allison, I think you should maybe give your views on that.
Yeah, I'll start with what it looked like here, at least. So again, it comes back to having that strong surgeon or anesthesiologist champion, like the leader essentially of it. And obviously it's important to be collaborative and enthusiastic and all of these things, but it should be expected that people show up to these meetings. And I think that's where that kind of strong leadership component comes into play, to put it delicately. But within those meetings, everybody has equal say at the table, and you go over the compliance for that week or that month or whatever it is, whatever your cadence is, and then you discuss why the compliance is good or why there's challenging components of that particular item. And then right then and there, everybody around the table can then solve that problem, like in a very practical sense, because you have everybody at the table who can actually affect that change. And so that's what it looks like just in a general way. But what we did here is we would always come with a report every month that went over exactly where compliance was good and where compliance was not so good, and then talked about each one individually as well as outcomes.
Yeah, I'd like to get engagement from everybody involved as well. So I would typically recommend the teams to rotate every now and then for a different profession to actually present something from the data, because that's a way to get to know the data a little bit better, and it gives you the opportunity to focus on something that is of your interest and maybe an issue that you'd like to get support with. Maybe it's something that you think the other guys are not doing well to make it difficult for you, whatever. But to actually use the data to bring your argument to the table. And I think that helps quite a bit, actually. The other thing with the data that find extremely important is that you report back to everybody involved. And it's extremely important that you don't forget any certain group. One that I've seen many times being forgotten is part of the night shift. You've done maybe 1 or 2 of the night shifts, it might be 3. And then the third one, for some reason, is forgotten. And then things start to happen. Lastly, to the involvement also is crucial when you have new trainees coming in, surgeons. You need to have them informed exactly how we do things here and move that very, very clearly. There's a question, if there was one tip you could share about getting buy-in, what is it? Nice to know what might come up is a question here. So I'm gonna pass that around to everyone.
Well, I can start, and I would say it's speaking the language of whomever you're speaking with, right? So if I'm talking to, or if I'm the surgeon champion or whatever, and I'm talking to a nurse, I'm not going to go into the very surgery specific types of details. I'm going to talk to them about what they care about, right? Same thing with your data people or your research coordinator or whoever it is that's kind of your support staff. You want to speak that language to them. And again, same thing with your administration. You want to speak that language of administration. So it's about gearing your messages to your audience, really.
Ryan? I think it's and you mentioned at the very beginning, is trying to do the right thing, right? Nobody comes to work saying, I really want to screw things up today, right? So when you pitch it like this, this is actual evidence-based to try to do the right thing for our patient. And this is at least I understand what you've been doing for years has seemed to work, but there's a chance to make stuff better with evidence behind it. And if you can get their attention a little bit on that, nobody wants to not do that, right? We all want to do that. And so that's the part that I think has been the most useful, is to say, look, we're just trying to do the right thing and this can help us. And that seems to help break down some of those walls too.
Sure.
Richard?
I would say one of the things is logistics that go on in the background. The protocols are really straightforward, and each institution has a computer system and some policies and procedures that have to be activated. And that takes a lot of different kinds of committees, and it takes informatics. And so just bearing in mind that there are a lot of things that go on behind the scenes that make ERAS happen, and that to make it easy to do the right thing through the systems that the hospitals or the health systems have, because they're kind of complicated. So that would be one of the keys, I would think, from my perspective.
I've seen many places actually use data again especially to convince some of my colleagues to do something a little bit differently. And by simply, you could do it anonymously as well, but just have surgeon A, B, C, and D and get the reports on their outcomes and what they've actually been doing as far as compliance. Again, it comes back to doing it with respect for everybody's, experience and practice and so forth, but also sort of leaning on the fact that what Ryan said, nobody wants to go to work to do a bad job. We're all here to help our fellow men and women, actually, and we want to do it as best as we can. And I think we never get too old to actually see if somebody else is doing something very nicely and getting better results. We start to wonder, okay, hey, what is the trick behind that? I want to pick that one up as well. And that's the kind of sentiment that we like to use, because it's a nice way to move forward and gives people respect, and that works very well, actually. Another question, did you get a lot of pushback when you began the ERAS protocol process? I could start off by saying I mentioned I invented the carbohydrate load. We were the worst group of all of them. When we started, we were 5 of us. When we started review the data, I was head of anesthesia at that time as well. But it turned out that we had 2 anesthesiologists just didn't like anything but NPO. And so we had the worst compliance of all. And it wasn't until we started to measure that we actually knew. And it took some discussions to actually have those guys on board. Yeah, and the same guys were also worried about doing it for the elderly people. But again, we used data to convince them. Yeah, anybody else? Yeah, go ahead.
I would say that would be true and also in formulary decisions. So if the medication, for example, is not on the patient on the formulary, but the data show that it reduces complications and length of stay, then that's the thing that needs to happen, and that's the right thing to do. So get that on the formulary.
And especially in your own institution, then there's really no hiding anymore. It makes it very difficult, doesn't it? Okay.
So the data can be used as a carrot or a stick, depending on the situation, I guess. But
well, you can. Yeah. Well, you're right. Okay. We have a couple of more quick ones. Any data on experience with ERAS in obesity surgery centers? Yes, there is even a guideline on ERAS in obesity. It's being updated, so there will be a new one coming out fairly soon. And the question here, why carb load versus saline? I'll take a quick answer to that. Carb load is getting the insulin response to change your metabolic state from a fasted state to a fed state. Saline will never do that. And saline actually should be, in my view, avoided. You shouldn't use it unless for very specific reasons. And then one that I know is of interest for the US, I'm going to hand it over to you guys. What is data on implementation of ERAS and reduction of opioids and early return of bowel function? So who could give a quick update on the opioid data in the US with ERAS?
Well, I don't know the numbers off the top of my head, although there's certainly a lot of literature out there. But opioid reduction within an ERAS protocol absolutely fits into this epidemic that we're having in the United States. And so here at our institution, one of the ways we got the orthopedic people on board was really hammering on the reduction of opioids and that sort of thing as a component of an ERAS protocol. So I can say that is certainly a very appealing portion of the protocol, although I certainly don't know the literature off the top of my head.
But I think go ahead, please.
Some of the data that my group have been working on is to look at morphine milligram equivalents and the impact on postoperative nausea and vomiting and length of stay. And in fact, in both colorectal and gynae patients, gynecological patients, you reduce MME and you reduce complications, postoperative nausea and vomiting and length of stay. So that'll be coming out soon.
Yeah, I'll just finish off with two really quick questions, or three actually. How often do you review the data with the healthcare team? We do it more often during the training, and then usually it would be once a month or every 6 weeks or so is where people tend to end up. There's a question, if the ERAS Society tracked the percentage of institutions that have ERAS protocols. No, we don't. A lot of people claim they're doing ERAS, but in fact, like I said, compliance is probably at best 50, 60% in most cases. There will be exceptions, of course. And then last question is if ERAS can be can be used for outpatients as well. We started with the bigger cases because that's where the biggest gain was to get, and that we've been moving in this direction. But there are outpatient issues or publications also out there with a standardized evidence-based sort of approach, and that should work fine there as well. Okay, well, that's all about the time that we have today. I would like to thank our audience for their participation. I really hope you get involved with ERAS And like I said, our societies are happy to help you. And if you are already involved, thank you. And also, you're more than welcome to join us in the discussions and everything else that we have to offer. You don't have to get our training. But I do hope that this session was useful for everyone, for those who did it, as a refresher and a reminder of to audit, and to others to give you some good background. Now, to claim the CME credits as MIPS improvement activity, complete the activity post-test and evaluation at the link provided. And over the next 90 days, actively work to incorporate improvement in your clinical practice from this presentation. And if you complete the follow-up survey from CME Outfitters, we'd like to see that as fast as possible, but no later than 3 months. CME Outfitters will send you confirmation of your participation to submit to CMS testing that your completion of a CME for MIP improvement activity. And don't forget to visit the CME Outfitters website for certified activities. Again, I'd like to thank also my co-panelists. It's been a pleasure to have you on board. Great to see you all again. And I hope to see you soon again. And also thanks to our organizers for a great job helping us manage the techniques, not least. So thank you all again, and stay safe out there.